This is the November meeting of the acute myelitis working group. Welcome everybody. Thank you for being in the meeting. We have a program this afternoon that is going to be dedicated to the discussion about what is going on around the major problems that we are dealing with, respiratory illnesses that are increased in many areas of the United States and the world, and also how is that related with acute myelitis. So we have invited our colleagues at the CDC to provide us with an update about what is going on with enteroviruses, AFM, and respiratory viruses in general. And thank you to Sarah, Adriana, Janelle, the CDC for providing this overview of the epidemiology. After that, we are going to have our colleague, Kevin Mesakar from the University of Colorado, and later Dr. Jelti Hefferik from Netherlands is going to give us an overview of what is going on in Europe. So with that introduction, thank you very much. And again, Sarah, go ahead, please.
All right, great. Hello, everyone. Good morning and good afternoon. I'm hoping you can see my slides and hear me okay.
Perfect.
Okay, great. All right, so yeah, I'm Sarah Kidd, and I'm just going to be presenting some CDC updates on EVD68 and AFM, as well as a really brief update on the polio situation in New York State on behalf of our CDC, AFM, and domestic polio team. I believe Adriana Lopez provided some of this information at the last session of the AFM symposium back at the beginning of September. But in August of this year, CDC was notified by both healthcare providers and hospitals in several regions of the United States that we were seeing increases in severe respiratory illness in children who also tested positive for rhinovirus or enterovirus or RVEV. As you know, rhinoviruses and enteroviruses can have clinically similar presentations and are indistinguishable from one another on most of the multiplex assays that are most often used in clinical settings. However, when typing was done on a handful of these, many were positive for EVD68. So that was the first clue that we were starting to see an increase in EVD68. At the same time, there was an increase in RVEV positive respiratory specimens in our laboratory-based surveillance system, the National Respiratory and Enterovirus, respiratory and enteric-virus, I should say, enteric-virus surveillance system, which is a laboratory reporting of their results to CDC. And at the same time, we also saw an increase in EVD68 detections among children with acute respiratory illness in the new Vaccine Surveillance Network, or NVSN. Between April and August of 2022, EVD68 was detected in children and adolescents with respiratory illness in all 7 NVSN sites. And the number of detections between July and August 22 was greater compared to the same period in any of the previous 3 years of 2019, 2020, or 2021. So this slide shows a figure that was published in MMWR last month, and it shows data through the beginning of September. And it's showing the percent of children with EVD68 detected among those who are positive for RV or EV and NVSN. And each line here represents a year, a different year's worth of data with the MMWR weeks at the x-axis. And just to orient you, week 35 coincides with the beginning of September. So the first thing that you'll note here is that 2022 in the black line, there was actually a early peak in EVD68 positivity back in, let's see, that would be April or May, and that was driven just by 1 or 2 of the 7 sites. But then by summer, which is the typical enterovirus season, all 7 sites were having detections, and the peak was even higher than we'd seen in any previous year, including in 2018. So this was in 2022, we reached almost 60% of all RV-EV positive detections were due to EVD68 in about mid or late August. So this prompted a health advisory alert, or HAN, that went out on September 9th to alert health departments and clinicians that RV-EV respiratory disease and EVD68 in particular were on the rise. And at that time, CDC had not received increased reports of AFM cases at that time. However, because in the past, we know that increases in EVD68 respiratory illness usually preceded EVD68 peaks in AFM by a few weeks, the HAN did focus on alerting clinicians to be vigilant for signs and symptoms of AFM in the coming weeks. So our AFM and domestic polio team was on high alert and was bracing for an increase in AFM this fall. And this figure shows AFM reports of suspected cases of AFM by the week that the report came into CDC. So not necessarily week of onset, but when they were reported to CDC. And again, these aren't representing confirmed cases, but cases that clinicians or health departments, they met certain criteria to be considered as possible cases of AFM. And again, we have MMWR week on the x-axis, and 2022 is shown in red. 2021 cases by week are shown in gold. And then in the blue line is showing an average of the peak years of 2016 and 2018. And so you can see that again, by week 35, which is again is the beginning of September, we were starting to see the red line of 2022 starting to track more closely with the blue line, indicating that we are on track to see a peak year in AFM. And so we were bracing for that. However, you can see that in subsequent weeks, it didn't follow the blue line. It seems to have reached a new baseline, perhaps slightly elevated compared to 2021, but nowhere near what we had seen in previous peak years during the same time period. And then this figure is showing the number of confirmed AFM cases by month of onset. And you can see that we've had a total of 29 confirmed cases with onset in 2022 to date, and we've not seen an increase in confirmed cases so far. So back to the viral trends and what we've observed. Again, in NERVS, which is our laboratory reporting, laboratory-based surveillance system, RV-EV respiratory test positivity has decreased since the September peak. It peaked at around just over 30%, 32-ish%, is now in the low 20%. Similarly, in NVSN, EVD68 detections among children with acute respiratory illness appears to have peaked in early September. And although we're still seeing EVD68 detections in most, if not all 7 sites, at least through mid-October is when we have good data for, it's again come down significantly from the peak in early September. And then in terms of our AFM surveillance and testing, we have not had any EVD68 detections among confirmed AFM cases in 2022, but we have had a single EVA71 detection from a stool specimen from a confirmed case. I also just wanted to toss in the BioFire syndromic trends, which is publicly available on their website. And this is showing percent positivity for different pathogens on their respiratory panel. And you can see this, the top blue line is RVs and EVs. And you can see just very similarly to what we've observed with the CDC lab data, the RV-EV peak appears to be September, maybe a little bit later in these data, late September or early October. but has come down in the last few weeks. And then finally, I just wanted to give a really brief update for this group about the New York State polio situation, just to keep thinking about polio in the back of your mind. The good news is we have not had any additional paralytic cases identified, so we just have that single case, and it's been now 3 or almost 4 months without another paralytic polio case. However, we have continued to have wastewater detections of poliovirus type 2 in several New York counties. And these figures are taken from an MMWR update that was published just a couple weeks ago. The figure on the left is showing the counties listed on the y-axis, New York City at the top, and then 8 New York counties where a lot of wastewater testing has been done. And the light blue boxes are showing wastewater that was tested but negative for poliovirus, and then the darker blue symbols are representing poliovirus 2 detections. And you can see that of the 8 counties tested, 4 have not had any detections. Starting at the top, New York City has had a few sporadic detections, none in recent weeks. Rockland County has been persistently positive. Putnam County was negative. Orange County has been persistently positive. Nassau County had a single detection, but has been subsequently negative. Sullivan County had some series of detections in the summer, but now more intermittently positive. And then Westchester, Suffolk, and Ulster have been negative on testing. We're continuing to do wastewater monitoring and surveillance in the area, as well as doing active surveillance for additional cases through syndromic surveillance and following up on those cases that meet certain criteria that are in a geographic area, and investigating to try and rule out polio in those. And as well as we have a team on the ground helping with the local health department to try and work with the communities, increase vaccine acceptance in the area and vaccine uptake to increase coverage.
Sarah,
So,
I have a question.
Yeah, perfect timing. Yes.
Can you go back to your graph?
Mm-hmm.
So you have the triangle that says P2 positive, not genetically linked to patient, and then you have square P2 positive linked to patient unknown.
Yeah.
Okay, so can you explain what the difference is?
Yeah, so as you know, every poliovirus that's detected is sequenced both to get information about the type of poliovirus and then attempt to get a full sequence to judge how closely related it is or whether it is related genetically to the virus that was isolated from the case patient. So the circles represent ones that were able to get sequenced and genetically linked to the patient. The triangle, there's a single triangle in New York City that was able to be sequenced, and it actually was not linked at all. So it was a different polio. It was I can't remember if it met the definition for vaccine derived or Sabin-like, but it was not wild. It was
yeah, there shouldn't be any wild, but
right,
you're not sure if it's
right. So that would make sense. Yeah, I just can't make anyway. It
So
was
is
not
that
related. They knew enough that it was not related to the virus from the case. It was a separate one, and no known linkages. And then
so that has no known lineage. No, so it's of unknown lineage. So it's not related to anything that we've seen in England or Israel, or
That's
even
correct.
some of the African endemic CVDP type 2.
That's correct. Yeah.
And then the square is
that this is an interesting another topic for discussion, but it's they were not able to get enough sequence to assess linkage to the patient. It was clearly a poliovirus type 2, but not enough sequence. And the MMWR describes that some of this is probably related to New York City. The sewer shed is huge and above the what's recommended by WHO. So the circle that's in New York City was done by a different method, and that's and to get the genetic sequence linked to the patient. So we're, and our lab is, Janelle, you may want to be able to say a little bit more, but our lab is following back and doing that same more intensive method for some of the other previous samples, but yeah, that's the information about that. That's what I can say.
So,
I can say a lot more. Yeah.
so you must have enough for VP1 and the 5' UTR to determine that it's polio, as well as that probably 481 has reverted. And then you're going to use a more, if I understand correctly, you're going to use a more intensified sequencing methodology or whatever to clarify the squares. Is that correct?
We're not going to be able to clarify all of them, but enough from previous samples. I think this is a bigger discussion. It's a different, it's actually more about concentrations and doing culture, and yeah, so we can follow up with
so
you
when
on that.
you so doing culture suggests that you're growing it on L20Bs, so that there's infectious
I'm not going to be able to comment on that level of detail. I don't know, but yeah, we can connect you. We can follow up offline, Amy, with our lab folks.
Okay, great, thank you.
Emily, you raised your hand.
Yeah, can people from the CDC just tell us whether there's been a surveillance year in the past that you had a large outbreak of EVD68 and respiratory disease, but not a temporally associated outbreak in AFM cases? Or do the surveillance systems were they not built to detect that sort of thing? Do you understand my question?
I think it's more the converse, Emily. We so it was 2014, both a big respiratory disease year and AFM year. 2016, it was more of an AFM year and less of a EVD68 respiratory disease year. 2018 was both. And then we have recent years.
Yeah, my question is continuing with Emily's question. It's like previously when 2020 or not 2020, especially 2018, 2016, when we have seen the peak, mostly AFM cases start coming up in large number across the country 3 to 4 weeks after. So we have seen peak in this year sometime in July and August, and now we are in September, October. So in that case, is there any sequencing being done with the new EVD cases to know if there's change in the virus or something like that? Or is there any discussion about it? Why we don't see any AFM cases in the large number anymore?
I think there's lots of theories. Yes, there is sequencing going on. I believe, Janelle, correct me if I'm wrong, the ones that have been sequenced from NVSN have all been clade B3, which is the same as same clade was detected in 2018. So, but whether there's some other key genetic differences, I think, are to be seen.
Yeah, it's a good problem. I'm fine with that if we don't see any AFM cases, just EVD68 outbreaks, but just it will be interesting to know why it's happening. Thank you.
Most of the graphs are presented as sort of percent of EVRV detections, and I know this might be a hard question to answer, but I'm wondering if the absolute number of EVRV detections is comparable to what we've seen in prior outbreaks, or if we're seeing a high percent of a small number. In other words, are we not detecting as much AFM because this outbreak is not as large as the prior ones, or is there truly something different about the characteristic of the currently circulating isolates?
Yeah, good question. And yeah, good pick up on and attention. Part of it is the nature of the surveillance systems, especially the laboratory-based ones, is that the reporting is based on the tests that were done. So if there were changes in testing, it's hard. So it's hard to assess absolute burden from like the nerves. With NVSN, we're showing you positivity just because there's some slight changes in methodology, but yes, there was a higher burden. I think we here in this blue box here is descriptive of the actual burden. So looking at similar periods to previous years. So this is also complicated by 2022 was the first year that sites were testing year round and not during the season. But if you look at comparable seasons, 2022 was a higher burden year, at least comparable to 2018, if not more.
Got it. Thanks.
Thank you so much, Sarah, and the CDC group for this update.